Hi, Dr. Nyame. Can you tell us what kind of doctor you are?
Hi. Hello, so I'm Yao Nyame. I'm a urologic oncologist at the University of Washington, and also a prostate cancer researcher, both at the University of Washington and the Fred Hutch Cancer Center here in Seattle.
So, do you do surgery on men with prostate cancer?
Yeah, so my primary practice involves treating prostate cancer with surgery, um, mostly with the removal of the prostate done robotically.
Great. And today's topic is on disparities, healthcare disparities, with a particular focus on Black men in America. Um, uh, we'll talk about the genetics and genomics, and the biologically significant issues, if there are any from your point of view. We'll certainly talk about access to healthcare, and social issues and challenges and racism and prostate cancer and seeking prostate cancer care. But I mean, maybe a good way to start is what do you say to a doctor who says, I treat all my patients equally?
That's a great question. I think physicians aim to treat everyone the same, but there are biases, implicit biases. There are issues that surround just institutional access to care and structural issues that can impact the way we deliver care. And so, it's a hard question to answer because on an individual basis, perhaps physicians don't see themselves as being biased or providing different types of care, but insurance status, location. There are so many factors that create barriers that can actually impact the type of care an individual receives.
Yeah, one of the sort of tropes that people are banding about in my psychosocial world is cultural competence. We must get our physicians up to speed on that. What actually does that mean in a practical, you got a guy in front of you kind of consult situation?
Yeah, I mean, that's a very complicated scenario and question because you have to understand that people have lived experiences that shape the way that they interact with their surroundings, right? And so when we talk about cultural competency, it's not just about language, but it's about understanding what values an individual has. And so the things that you value are going to be very different from the things that I value. And creating creating systems that allow us to tap into that sort of component of an individual patient's experience and priorities is important. These are things that are starting to make their way into medical education and graduate medical education. So residencies and fellowships are starting to think about how to do this. But one easy or one straightforward way that this can happen, is by just having better representation in medical schools and residencies and departments. Because sometimes it's having the discussions offline between providers and with colleagues that you get to understand why certain things may be important to different populations.
Yeah, and when we talk about Black men, it's not like there's one size fit all for men of color. Can you talk a bit of cultural things that doctors should be concerned, be more up to speed on relative to men from African descent, men from the Caribbean, men who've, whose family go back 200 years, or to, the diaspora, and men who are newly arrived, whose families are newly arrived.
Yeah, that's a great question that you ask, and this is one of the things I struggle with as a disparities researcher. Is I think oftentimes we take this social construct, which is race, and we say we apply a lot of biology and other things to it indiscriminately. So you raise a very good point that perhaps as someone who's part of the African diaspora here in the United States, that is emigrated because of education, may actually have a social and economic standing that's much different than a urban, Black American who's been in this country for, whose family has been in this country for a much longer time and experience a very different social pressure that's, you know, rooted in things like racism, poverty, etc. And so we have to disentangle a lot of these social constructs when we start thinking about race and the provision of care.
Yeah, and I'm sorry. Yeah,
Yeah.
and the provision of care. I mean, in you know, layered on top of how do we provide, you know, adequate, affordable, durable care to everyone. When men of color approach a hospital or sit in a waiting room, is, from your disparities research and your personal understanding and the understanding you've gathered from your patients, is it different for men of color? Is being in a waiting room different for men of color relative to the waiting, the people around you, the anticipations, expectations?
Yeah, that's a good question. Well, we know that Black men and men of color receive their care at different institutions and their counterparts. Um, you know, there's a deeply rooted history of mistrust with the medical community here in the United States that goes back, you know, all the way back to slavery. And so, um, yes, I think the experience that one has as a man of color with the healthcare system is really different, and it's the onus is on us as the medical community to really start rebuilding those relationships and re-engaging men of color to have more trust with their facilities. Because I do
Yeah.
think that in the current status, it is a very different relationship, and it's one that's hard for people on the outside to sometimes understand, right? Because you need care. Imagine having a cancer diagnosis but not feeling that you can fully trust the providers that are out there trying to take care of you. um, for some folks that might not make sense at all, but for others that's a real and lived experience.
Yeah, and you know, it's good you mentioned it goes back to slavery. So many times, also one of the tropes in my social work field, and probably just generally in healthcare, you know, Black African American men don't trust healthcare because of Tuskegee and Harriet Leaks, but it's really not specific to those two particular issues. You know, instances. I mean, you know, I mean, it's the experience is different from the day you're born to the day you die. You know, and you know, hospitals in themselves are institutions comparable to other institutions, you know, and men in white coats and stethoscopes around their neck are wearing a uniform, you know, and interactions with people in uniforms is a different experience. Does that make sense, or what do you think?
Yeah, no, it's a good point. You know, obviously things like Tuskegee um, are among the most egregious offenses that the medical community has imparted on, um, you know, the Black community. But there have been instances, as I've mentioned, that go a long way, and it hasn't all. You know, you have to think about the history of how medical research was done prior to patient protection, and so. It's not just the Black community, but any vulnerable population really has a history of you know, being taken advantage of in medical research prior to the protections that we have in place now. But those things become part of your narrative, right? As a community, if these are things that you experience over and over again, and it's something that's affected you on a generational standpoint, then it's hard to turn around and really want to engage in things like research or care unless it feels like it's an absolute must, you know. And so, to your point, things like the uniforms may keep people at arm's length. You know, when I was a trainee I had my chairman always refused to wear a white coat, and he said that, you know, he felt that it was more humanizing for him to just walk into the clinic room with his shirt and tie on than to have that white coat. He felt it was a barrier to patients. And that's something that always stuck with me, that the little things that we do can help build relationships and trust. Something as simple as taking off that white coat.
Yeah. So what is the current disparity? What's the difference in like health-related outcomes, Black men versus white men in the United States?
A great question. There are two buckets that I think we need to think about. The first one is incidence, so the number of new cancer diagnoses in a given year. And if you look at incident cases for prostate cancer, Black men are 70% more likely to be diagnosed with prostate cancer than men of all other races. And that in of itself sort of introduces some interesting hypotheses as to why that would be. You know, the easy one that folks always try to point towards is biology. And certainly biology probably plays some role, because we know that prostate cancer is a highly heritable disease. So we know men who have strong family histories are more likely to be diagnosed with prostate cancer. But you can also think about how environment and social constructs could lead to exposures, life stressors that might actually be pro-cancer. So a pro-inflammatory state, for instance, might be something that is more likely to lead to a malignancy in a man. And so there's a lot to disentangle in that incidence number for Black men. On the other side, you have mortality. So are you more likely to die from prostate cancer? And we know Black men in the United States are over 2 times more likely to die from prostate cancer compared to men of other races or ethnicities. And that, I think, highlights additional challenges, because, you know, if you wanted to be a cynic and say, well, if you're 70% more likely to have cancer, so you should die at a rate 70% more, then we still have excess death above what the incidence disparity is. Yeah, and I would argue that really what we should be fighting for is parity in outcomes related to death. And so then you start thinking about sort of equity model of care. So how much more do we need to do for Black men in the United States for them to have similar outcomes to men around them? And that really starts to get to, at least for me, as a in my current view of this issue, you start to get pretty far away from biology only solutions, and you really start to drive more towards what I call health services. So what can we provide men with regards to screening and treatment that will create better outcomes for them?
Yeah, and we'll get into that in 5 to 10 minutes. but so the disparity is clear among Black men versus white men. Prostate cancer killing more Black men than white men. Higher stages of diagnosis initially for Black men than white men. Are these comparable disparities to other disease states? I was reading earlier today that Black men with breast cancer, male breast cancer, have comparable death rates. Are more likely to die from male breast cancer than white men with male breast cancer. And women with breast cancer, I think, have a similar kind. I mean, is this just across the solid tumor spectrum, or what do you think?
Well, it's interesting, and it's a great question that you ask. There are so many diseases in the United States, both within cancers and outside of cancers, where we see disparities in outcomes that are more pronounced in the Black community and communities of color. Within cancer, definitely the largest racial disparity you see is in prostate cancer. But as you pointed out, we see these relationships in colon cancer. We see them in gynecologic cancers like endometrial cancers, and we see them in breast cancer. This goes back again to this point that as much as we try to look at biologic solutions for this, that there probably is a systems issue that reflects access to care and utilization of care just as much, if not more, than a biology issue.
Yeah, and in a way, I mean, one would almost say that if it was a biological or even a genomic issue, there's ways to repair that or at least investigate and come up with a solution. The system issue is, I mean, do you change 300, 400 million people in a, by vaccinating them? I mean, how do you fix that? And one of the interesting things as I've been learning of this is around the military, that it seems to even out the disparity. I mean, not 50-50, but it reduces issues for Black men versus white men and other men of color, women of color. I mean, what are your thoughts on military versus civilian life?
It's I'm going to answer this way. Excuse me. There have been several studies that have shown that with equal access to care, that disparities seem to decrease markedly, or in some instances you have parity with regards to prostate cancer outcome. The most recent study really says that not only do you have to have equal access to care and treatment, so appropriate use of definitive treatments like radiation or surgery for localized cancer, but you have to match the men stage for stage and grade for grade. And you highlighted something, which was that Black men are more likely to present with advanced stage disease and some studies have suggested more aggressive disease. So this goes back to this idea for me that the solution isn't just give everyone access to treatment. And in some of the VA studies, the Veteran Affairs study that you have highlighted, suggests the same thing, that again, when you look at groups of men who've had treatment, that the outcomes are pretty similar. But you got to think about what is happening on the front end of that. How are men getting screened? How are their cancers getting detected? Are they getting detected early enough that you can actually apply that intervention and reduce their risk of dying from cancer?
Yeah. And early detection we'll get to in another 5 or 10 minutes. But let's talk a bit about the biological presentation issues and see if there are any. I mean, so is there anything to be made of race and disease outcomes?
Yeah, so biology is interesting. I can tell you that to date, there is no clear biologic signal that says, hey, this is why Black men have a higher risk of being diagnosed or a higher risk of dying from prostate cancer. There are certainly differences that have been reported between Black men and men of other races. Predominantly, those studies are comparing men of African ancestry versus men of European descent. And those differences have shown us that perhaps Black men are more likely to have cancers that have immunologic profiles or immune signaling. This may have some impact in personalized medicine decisions down the line. But I always think of biology as being a personalized medicine issue. So on the individual basis, biology can help it. Is going to really have a large impact in how we treat people. It's already doing so, right? We're seeing landmark papers in our field that are based off of, your underlying germline DNA. So sort of the material you're born with and how that impacts your cancer might make you a good candidate for a certain drug. But when I think about disparities on the population level, then it seems like the biology starts to become less significant in that equation.
What about like environment?
There's so many great questions with regards to environment. I touched upon this when we started. I mean, you can think of environmental exposures. You can think about life stressors as being things that could impact your cancer risk. The challenge is in how we study that, right? Because oftentimes when we design trials, we're really engaging with patients at one time point. So let's say you get a group of men between the ages of 55 and 75, and you get tissue from them or you get blood, and you measure something, and then you try to impose a lifetime of exposure off that one particular interaction. And that always makes it very challenging for us to say, you know, did you get enough sunlight, or how much stress have you really been under your life? And these things probably, from an exposure standpoint, occur over we're talking decades to potentially give you that biologic risk, which we capture as a new cancer diagnosis. So you can look through the literature. I mean, we talk about obesity, and smoking, and vitamin D, and a lot of things have been tested. But when we do the larger prospective trials, sometimes these things just don't bear out the way we want them to, as far as the impact of being on a healthier diet or exercising more, etc. So they definitely have a role, but I don't think we've come up with a very sophisticated way to study it yet. But it's an area of interest for so many folks that I do think we'll continue to make incremental gains in this area.
Yeah, and we'll probably learn that it's just the common sense changes and interventions will be helpful. But yeah, the idea that one grouping of people based on race or even economic strata or lifestyle or sexuality or gender has higher levels of stress and thereby is more likely to die from a particular disease state. I mean, it's such an easy song to sing, but it really doesn't help anyone to sing it necessarily. And in fact, it causes more stress, perhaps.
It does. I mean, but I think that we have examples in the medical literature of, stress being a source of disease. We see it in cardiac literature and other places. So, yeah, I think that it's a hypothesis worth investigating. It's probably a hypothesis that is hard to solve without large structural changes, and so those are two really separate issues. If you're asking me about environment, stress, that kind of thing,
yeah.
It's one thing to study it, but how do we fix it? Even if we identify it, that's really the challenge.
And are these issues? Is our conversation genuinely unique to the United States, or can similar conversations be held in England and Argentina, in Dominican Republic, perhaps? Or...
No, I think that they are generalizable to other parts of the world. When you look at the global burden of prostate cancer, the highest rates of mortality actually are in places with large populations of men of African descent. So West Africa, the Caribbean, or the U.S. are among places with the highest rates. The question is, what is driving that? As far as those high rates of prostate cancer death, and I don't know how much of that can be placed just on environment and stress. I mean, there are other things like access to care and that are common threads that are shared between those different locales. But I think the concepts and the frameworks that might ameliorate disparities in the United States hopefully can be expanded to other global areas where the burden of disease is high.
Yeah, we have this. We're the founding organization of the Global Prostate Cancer Alliance, which are organizations around the world, 32 of them, similar to Mail Carry and patient support and advocacy organizations. And almost all of them, to a country, even in Iceland, are very interested in the work that we're trying to invest in, and trying to understand the guys in our support groups who are coming in and saying, I didn't get the same care that guy got, or, my PCP referred me to the local hospital. Why didn't he refer me to, a Sloan Kettering or a Cleveland Clinic or University of Washington or something? these are things that are transposable, it seems, also just not to men of color, but to migrant communities, to any kind of community where people feel suspicious of the larger institutional offerings around healthcare. So I think, it just drives me insane that there's so few research and investigations and funding for these, that such fascinating topics that can reveal solutions for all men, not just men in certain stratas and cohorts. Let's talk about what men of color, Black men, can do today, even guys that are pre-diagnosed, that may have wandered onto this conference because I don't know what, but but certainly we'll hear about it from people who are watching, and I encourage everyone who's watching this to share the message that you're learning throughout all 43 of these presentations throughout the world, through your neighbors and such. What should people, screening is obviously a thing. What should men who are 30, 40, 50, what should they be doing or thinking about?
That's a great question. I think there are a few things to consider. The first is know your family history, and try to know your family history to the best of your knowledge, because I think family history among Black men and men of color increases risk just like it does the general population. Understand screening. It's we've made prostate cancer screening very convoluted and complicated. The facts are that prostate cancer screening reduces mortality risk by 20%. If you look at the population statistics in the United States, since the introduction of screening in the late 80s, we've seen deaths go down by about 50%. And now we're actually seeing the increase in advanced cases over the last few years, coinciding with decreases in screening. So, I think Black men need to have, and men of color need to have that discussion with their primary care physicians about the value of screening, especially in a population that has a higher risk of adverse outcomes from their disease. And then I think, find community. And I think that's the power of, patient support groups and, networks that exist across the country that help people understand what it's like to go through this process, so that they don't feel alone while they're doing it, whether it's, the screening side of things or the treatment side of things. And I find that when patients have other men or other members of their community, partners that can support them as they make decisions around their health, they have better outcomes.
Yeah. The screening thing, it just occurs to me, sounds almost like the anti-masker kind of thing. You don't screen, you don't wear a mask, health-related outcomes are going to be a lot more devastating than there would be if you do screen, you do wear a mask. There may be some sort of thread for that. Who knows? But it's an idea. Maybe it's a quizzical idea there, or whatever. But or whatever that word is, a fantasy kind of thing. But it does sort of hail back to this idea that if I know that the chances of me being diagnosed and the chances of me being diagnosed with an advanced stage disease and the chances of me dying are higher than for other people, why would I want to get a screening? What do you say to that? The fear of finding out becomes a barrier in and of itself. We want to build awareness, but then is the awareness constructing a barrier that keeps guys from actually following through?
A great question. Prostate cancer is highly treatable. When detected early, it's highly treatable. And I think that you have to keep that in the frame, as part of the frame of reference for the decision making. The benefit of early detection is having access to treatment modalities that can eradicate the cancer with a high level of success. You know, the alternative of waiting or letting the cancer progress in those that have what we term clinically significant disease or more aggressive cancers is living with advanced prostate cancer, the treatment of which does involve androgen deprivation, which has very serious systemic side effects that impact quality of life, right? So, to me, that benefit outweighs the risk. Now, I don't want to I don't want to be wholly biased on being pro screening because there are harms associated with screening. I'm learning this from my biostatistician colleagues, and we always have to reconcile those harms of, quote, over detecting cancers. So finding cancers that really were never going to be a harm to a man over the course of his natural life, plus just, the potential false positives, if you will, of a PSA test that lead to things like biopsy that are not benign. So, I do think it's important to keep that within the context, that to keep that context in mind. However, I think there are so many different screening strategies that have been presented that demonstrate that there are strategies that allow us to not over detect cases, over treat patients, and still use the screening tool to identify high risk men who benefit from treatment.
And, one of the things I hear a lot, and so I'll just ask you straight out, is this a racist construct? That this is what people say, that Black men are not doing screening out of concern about the DRE and that the digital rectal exam, and then along with that, sometimes I hear, and I from a major nonprofit leader just last Tuesday, that Black men uniquely feels that a DRE will turn them gay. Is that really a racist construct, or are there studies and is there any validity to this?
I think there have been early studies that have shown that the digital rectal examination has been cited as a reason for men of color to avoid screening. But in my own clinical practice and experience, I feel like there's a lot that happens. You talked about cultural competency. There's a lot that happens when you are able to just have an honest and candid discussion about things like risk and what the examination entails. And I have personally found that you can build trust and at least convince men to undergo screening. I think there's a lot to do with some of the things that we've talked about, like community. When I was a trainee at the Cleveland Clinic, we held a huge minority men's health fair, which was sponsored by one of the African-American urologists in the department, that drew a lot of men to come get screened. And I think in some ways, whatever barriers might have existed culturally, this health fair that occurred at the Cleveland Clinic created a safe space for men who felt like they would benefit from screening to come and do so. So, yeah, it's a complicated, question that you ask, but I think there are ways to circumvent that, and one of the ways is engaging Black men in how we build strategies for screening and making sure that their voices are being heard and how we implement, different strategies.
Yeah. And the classic patient's voices being involved in all aspects of care. I mean, it's a no-brainer that no brain really engages, very few brains engage on. And it's just this endless sadness that as we enter 2021, patients still don't feel heard or at least respected and acknowledged. One of the things we hear endlessly in our support group network is, it's not that, when people say men don't talk or men don't speak up, all the guys, like 99 out of 100 men and we have like 74,000 both online and in person, I mean, they'll all tell you it's not about like I'm not speaking. It's that I feel like I'm about to be judged, or I'm not going to be listened to. So why should I? I mean, I'm just, it's there's this extraordinary disconnect between what the patient is experiencing and what seems to be, taught to physicians and nurse practitioners and physician assistants, et cetera. And, it's so hard to fix that, Yeah. What, once a man is diagnosed, do you think Black men should seek out Black doctors, or does it matter?
Well, the truth of the matter is there's a limited resource in terms of urologists and specialists, radiation oncologists. You know, I think a strategy that would focus on matching patients and providers on race, ethnicity alone would be short-sighted. I think what we really want to do is build systems that allow for culturally competent and appropriate therapies to be delivered to all men, regardless of their race or ethnicity. Um, Obviously, there's some things that just can occur naturally if there are commonalities between provider and patient. And that's true whether you're a Jewish provider and a Jewish patient, or a Black provider and a Black patient, and so on and so forth. But yeah, I personally don't find that to be compulsory.
Yeah. Um,
Actually, I will say this. I would advocate for patients to try and get the highest quality care provider that they can find. And hopefully that's someone that they trust and have a good relationship with. That's invaluable.
Yeah, and I mean, we advocate that. I mean, we tell people. I mean, within our this prostate cancer well Black book I mentioned earlier, in our twice as many program, twice as many referring to disparities. That in simple terms, now's not the time to be progressive. Now's the time to take care of your health. I mean, you'll fight the battle when you get your care. But now, you seek the best care possible, no matter who that is, to a degree, But I mean, and I mean, it's the bottom line. I mean, cancer cells don't care who's treating them; they just fear who's treating them well. And we want everyone to get, have access to the best care. One of the another issue that comes up a lot is, are these drugs and therapies meant for me? I mean, it sort of refers, to small percentages of Black men in clinical trials and such. Let's look at that in two parts. First, I mean, we'll talk about getting more, what are the barriers to clinical trials and accrual and such. But right off the get-go, how does anyone come to trust and feel confident that these therapies and drugs are going to be effective for him?
Great question. You alluded to this. I mean, the rate of participation or inclusion, I should say, of Black men in clinical trials for prostate cancer has been really low single-digit percentages. So there has been marked underrepresentation. Interestingly, in sub-analyses of several clinical trials, both in the localized space and in the advanced space, we see that Black men either have equal outcomes, or in some instances better outcomes, with a variety of therapeutics, whether there be systemic agents or surgery, radiation, etc. I take all of those results with a little bit of caution, because there are selection biases. And we talked about this at the very beginning, that we have to be careful when we just apply the label of Black or African American to an entire population, not taking into account the massive amount of heterogeneity that exists socially, economically, and even biologically. within that category. As far as, is this for me? I mean, I think we have to start by applying standard of care therapies to everyone. So, if a drug has been shown to reduce risk in a randomized controlled trial, upheld to the highest standard, I think the starting place is making sure that men of color and, men who, are disadvantaged in some way are having access to that standard of care therapy. The next thing that's the onus that's upon us as a field then is to think about how we are more inclusive in our future trials, so that we don't have to keep asking this question of, well, this population wasn't well represented. Is this treatment going to be sufficient for them?
So how do we become more inclusive for trials?
Well, I think there are certain things that are important to consider. One is that now, NIH and NCI are definitely making it a requirement for trials that they fund and support. And I think a lot of clinical trial bodies are doing this, but they're making it a requirement for investigators to have better representation. And so that's a very big step. If you make it a requirement, it's going to happen. For me personally, and my colleagues here at the University of Washington, we're really focused on patient-centered research. And I think a strategy that's really effective is not only engaging your stakeholders and populations that you want represented in trial design, but I think you go to them and you ask them questions about what's important to them in their care, and you let that population lead the development of your research questions. And so I think there are a lot of really excellent and innovative patient-centered research strategies that allow men to not only develop the research questions that you want answered, but in that process, you help them become invested stakeholders in the design of your trials, and their voices are heard. And I think that allows you to, on the front end, understand, evaluate, and hopefully overcome whatever barriers may exist to getting inclusion of underrepresented populations in your trials.
Have you actually seen a trial that did a brilliant job of being inclusive?
Yeah, I think there have been studies, not that I have personal familiarity with, but there have been studies, for instance, in the radiation literature, that have managed to have better representation of Black men, for instance, with prostate cancer. We're in the midst of trying to figure out how we're going to do that in building cohort studies, and with goals of hopefully designing some clinical trials in the future that will address that. But it's a really difficult thing to do. I mean, we over this period of time that we've been having this conversation, we've covered a lot of ground of many issues that might not make a Black man that excited to participate in a clinical trial. And some of that, as we've alluded to, has strong historical context that has led to mistrust and a lot of other feelings that might not make someone eager to donate their tissue or participate in a trial where they feel like they're being experimented on. So we have a lot of work to do in this space, that's for sure.
Sure. And even within support group contexts, my end of it, people of color, black men are less likely to do a text-based online support group out of a fear that what they type in, even if it's de-identified, et cetera, will be used, either used broadly or used directly for them, but just that it'll be extrapolated and some external force will use it diabolically or not. But there's that concern. And it's sort of what we touched on earlier, the idea that awareness may in itself breed barriers, because it's highlighting so many negatives that need to be overcome, and so the paradox of you don't keep quiet, but if you keep quiet, things won't change, and I mean, it's good that prostate cancer is a slow growing cancer, but it's not, for most people, but it's not slow growing enough for social and clinical care changes to really demonstrate advances within half a generation or a single generation.
Yeah.
Yeah. Well, any questions that I did, any, things that I didn't touch on that you'd like to share?
No, this is very comprehensive. I mean, I think the biggest thing we can do around this issue is continue to raise awareness, continue to support research in this space, and continue to be inclusive. When I give talks about prostate cancer disparities, my first two slides are often the data from the SEER Cancer Registry, which is a US population registry. It dates back to the 70s. And I show these curves where we see that the rate of new cases is 70% higher in Black men compared to the rest of the population. And it's been consistently so since the inception of that SEER registry. And I show data that the mortality rate has been at least twofold or higher between Black men and men of other races and ethnicities dating back again to the 70s. And that relationship has stayed stable even as we've seen marked changes in the trends of the cancer statistics with screening, et cetera. So I think we're at a nexus where we really need to start having meaningful impact that leads to the reduction in that death difference between Black men and men of other races and ethnicities. And truthfully, I think finding those solutions that create parity are going to be beneficial for all men who are diagnosed with prostate cancer. And so that's the goal. The goal is to improve outcomes and survivorship and quality of life and all those things for all men. And I think one great strategy for achieving that is looking at our highest risk, most vulnerable populations and addressing their issues. And I really believe that will create a better outcomes for everyone.
Thank you for your care of your patients. Thank you for enlightening our viewers, and welcome to the conference. Thank you very much.
Really appreciate it.